clarify, this is a series aimed at helping our membership become more savvy in research methodology skills that will help them conduct their own clinical trials in the area of transfusion medicine. And unfortunately, we lost our speaker last month on explanatory and pragmatic trials, just due to a scheduling problem. But we are back on schedule now with today's talk on quasi-experimental trial design by Dr. Monica Taljaard. And I will hand the floor over to her after I have given a brief introduction of who she is for those who have not had the pleasure. Dr. Taljaard is a senior scientist in the clinical epidemiology program at the Ottawa Hospital Research Institute and full professor in the School of Epidemiology and Public Health at the University of Ottawa. She received her PhD degree in epidemiology and biostatistics at Western University in London, Ontario in 2006. And her main research interests are in the design, analysis, and ethics of pragmatic and cluster randomized trials. As a methodologist with the Ottawa Method Center, she works with clinicians and researchers from a variety of backgrounds in the design and analysis of their studies, including clinical trials and observational studies. And she has humbly asked me not to list the number of publications that and grants that she has received. I will simply say that they are both numerous, and so we're very happy to have her join us today. So at this point, I will give the floor to you, Dr. Taljaard, if you want to present your slides.
Okay, great. So I will share my screen. And thank you so much for that kind introduction. Just to say, I can't see anybody, so feel free to shout if there are any comments or questions or discussions during the lecture. I don't mind answering questions during or after as they arise. So great pleasure to be here today, and thanks again for the invitation. So what I'm hoping to accomplish is describe what cluster randomized and stepped wedge trials are. I'd like to explain the concept of intracluster correlation and its implications for trial design and analysis. I also wanted to describe some potential risks of bias and how we might reduce these risks when we design cluster trials and stepped wedge trials. I want to describe some key advantages and disadvantages of these study designs, and then give you some additional tools and resources in case you want to embark on designing your own cluster trial or stepped wedge trial. Where can you find further information that will help you? So let me just start by saying, what is a cluster randomized trial? So you probably know there are two main types of clinical trials: patient randomized trial and cluster randomized trial. So in a patient randomized trial, usually we randomize patients one by one, often happens within multiple centers, to either treatment A or treatment B. It could also be treatment A versus control, of course. But the key is that the randomization happens within these centers, and about half of the patients in each center receive treatment A, and the other half receive treatment B. In a cluster trial, it's quite different. Here, we randomize entire centers to either treatment A or treatment B, and all of the patients within each center receive the same intervention. So at least from a logistical perspective, the cluster trial design seems to be a little bit simpler in that there's no randomization that needs to take place within the center, and only one type of intervention needs to be administered in each of these centers. However, compared to a patient randomized trial, a cluster randomized trial has some major implications for the design, analysis, and interpretation. Number one, cluster trials require larger sample sizes often much larger sample sizes. Number 2, they are vulnerable to increased risks of bias. Number 3, they increase the complexity of the statistical analysis. So these are some serious concerns. The fact that a cluster randomized trial increases the risks of bias is actually an underappreciated fact. So often we see that these biases can turn cluster trials into something that looks more like an observational study than a robust randomized controlled trial. I'm going to say a little bit more about each of these things. So I'm going to delve into them. Firstly, why do cluster trials require larger sample sizes? Well, that's because in a cluster trial, the outcomes measured on different patients in the same cluster, say in the same hospital or in the same medical practice, are usually positively correlated. And that could be because of characteristics such as the type of hospital, the expertise of the provider, and so on. So there's some sort of a similarity among the responses that we measure on people going to the same cluster. So this correlation or this degree of similarity within clusters is measured by a very important parameter called the intra-cluster correlation coefficient, or ICC. So that's an important parameter in the cluster trials field. Because of the presence of this intra-cluster correlation, we have a reduction in what I call the effective sample size. And so to compensate, we need to increase our sample size. So basically, as we recruit more patients into our cluster trial, we're just adding more and more information that is similar to the information we already have, right? Because the outcomes are correlated with each other. So eventually we kind of reach a saturation point whereby if we add more patients to the cluster, we're not actually benefiting. We're not getting any unique information because the information we're adding is just more like the same, more like the information we already have because of this intra-cluster correlation. So that is a critical thing in a cluster randomized trial. I said cluster trials are vulnerable to increased risks of bias. Why is that? Well, that has to do with how patients are typically recruited in a cluster randomized trial. If you think about a patient randomized trial, here patients are usually recruited before they are randomized. So at the time where the patient is approached for informed consent, they don't know yet what arm they'll be allocated to. So they agree to be in the trial, regardless of what arm they're going to be allocated to. So as a result, the baseline characteristics of the patients in the intervention and the control arms tend to even out, which is what we want. That's one of the reasons why we do randomized controlled trials, right? We rely on that randomization to balance things out between the arms. But in a cluster trial, things are usually quite different. So in a cluster trial, patients are usually, not always, but usually identified and recruited only after the clusters have already been randomized. And that's because often in a cluster trial, we randomize sites and then we prospectively need to recruit the patients. We have to wait for the patients to show up for clinical care before we can recruit them into the trial. And often patients and the people recruiting them know what arm the cluster has been allocated to. So the consent is often with respect to being in a particular trial arm, as opposed to being in the trial. And the consent forms can often look quite different between the intervention and the control arm. So if the likelihood that a patient is going to say yes is kind of influenced by that knowledge of whether they're going to receive this new intervention or the control, then it gives rise to differences. That's called selection bias. There can be differences between the patients who agree in the intervention arm and in the control arm. So we often see this imbalance, not only in the numbers of patients who are recruited between the two arms, but also in the characteristics of the patients who are recruited. So that's a huge problem. It's called identification and recruitment bias. Doesn't happen in patient randomized trials, but it happens very often in cluster randomized trials. I also said cluster trials have increased statistical complexities. What do I mean by that? Well, basically, everything we learned in Biostats 101, in any introductory clinical trials course or any biostats course is out the window. All of those standard methods like a t-test, chi-square test, linear regression, logistic regression, these are all invalid. They give rise to they give us p-values that are too small, because basically those analyses treat the measurements as completely independent data, as completely unique pieces of information. And so our sample size is spuriously high. We don't truly have such a large sample size because some of those data are correlated with each other. And so our p-values would be spuriously small if we apply these standard methods. So to get the correct p-values, we have to use a more complex statistical technique that accounts for the ICC, and that's usually a hierarchical regression, something like that, a method that treats the cluster or the site as a random effect. That's a more complex statistical method. We can't just run a chi-square test and hope we get the correct answer. There's a second requirement, though, for obtaining correct p-values, and even experienced biostatisticians are often not aware of this second requirement, and that is the need for a penalty called the small sample adjustment. So the reason for this is all of our statistical methods are based really on assuming the patient is the unit of randomization, and we've randomized many, many patients. So these methods are large sample methods. But when we randomize clusters, we typically only randomize a small number of clusters, right? We can't afford to have a huge number of clusters or sites in our trial. So we often have a small number of clusters. And in that case, our statistical methods are actually not valid without this small sample adjustment. So the need for a small sample adjustment is critical. So as a clinical investigator, if all you remember is talk to your statistician about, if you're doing a cluster trial, did they remember to apply a small sample adjustment? Because without that adjustment, once again, we will end up with p-values that are too small. So I just want to summarize, and then I want to move on to stepped wedge trials. I just want to give you 4 key recommendations for good statistical practice with respect to cluster randomized trials. The first one is to use this design only when you really must. So generally, if you can afford, or if you can do a patient randomized trial, that is always the better design. So you really need a good reason to choose cluster randomization. And a good reason could be something like, my intervention is a cluster level intervention, or it's something that affects everybody in the cluster necessarily. There isn't really a way to do this intervention separately for different individuals and not for other individuals. So it's done at the cluster level. Or it could be that there's a huge risk of contamination. If you were to randomize patients individually, there might be some degree of contamination between patients randomized to different arms within the same center. In those circumstances, cluster randomization is probably justified. The second key recommendation is to use strategies to prevent identification and recruitment bias. For example, try to blind patients and those identifying or recruiting them. Third, obviously, we always have to use statistical methods that adjust for that ICC in both our sample size calculation and our analysis, and then also remember to use a small sample correction. Almost in all cluster trials, that is necessary. All right, so these are key recommendations for cluster randomized trials. Now I want to move on to a stepped wedge cluster randomized trial. So with a stepped wedge cluster randomized trial, the best way to really illustrate or explain this design is with a diagram. So the top diagram here is a standard parallel arm design in which half of the clusters, say, are randomized to the intervention and the other half to the control, and they remain in the arm to which they've been allocated to for the duration of the trial. Stepped wedge looks quite different, right? In a stepped wedge, we see this kind of crossover from the control to the intervention. So to explain more carefully what this design is, we have a design where all the clusters start in the control condition and end in the intervention condition. So they gradually cross over to the intervention, and this is done in random order. So there is randomization here. These sites are randomized with respect to these times where they're going to cross from control to intervention. Very important also to understand the outcomes are measured repeatedly in each cluster over time. So in each of these cells, we take measurements from that cluster. So everything here is anchored in calendar time. That's something that people actually misunderstand very commonly. All of the clusters in a stepped wedge trial have to initiate the trial at the same time. So they start the same time, take measurements in the control condition, and then the first batch of clusters cross over. Once again, we take a measurement, and so on. So it's all anchored in calendar time. So these outcomes that are repeatedly assessed in each cluster could be taken on the same patients over time. So this is called a cohort stepped wedge. In a cohort stepped wedge, we recruit the patients in the first period, and then we follow those same periods throughout the trial. So with a cohort design, all of the patients will eventually get the intervention. So not only do the clusters all get the intervention, but also the patients. All patients and all clusters eventually get the intervention. But in a cross-sectional stepped wedge trial, it's different. So here we recruit different patients in every period of the trial. This actually is also known as a continuous recruitment short exposure design, because it's kind of like where there's a continuous flow of patients into and out of the trial. So we might, for example, have a stepped wedge in an emergency department where the patients come in for care. We screen them for eligibility. If they meet the eligibility criteria, they get grabbed into the trial. They're exposed to either the treatment or the control, depending on what that site is in at that time. They get their treatment and then they go away, and then new patients come in. So there's this continuous flow of patients into the trial. And so obviously, the patients that are measured in these different periods of the trial are completely different patients. That's why it's called a cross-sectional stepped wedge. So with this cross-sectional stepped wedge, yes, all the clusters get the intervention, but not all patients get the intervention. So it'll end up being like almost like a multi-center patient randomized trial, in the sense that in total, only about half of your clusters will get the intervention and the other half will get the control. But of course, in some clusters, there's many more patients getting the intervention than the control, and vice versa. So those are the two main variations. So now I have an example for you in transfusion research. So I was not involved in this trial, it's just a useful educational example. With this stepped wedge trial, they aimed to evaluate whether a point of care blood test within the context of this integrated transfusion algorithm can reduce red blood cell transfusions. So these investigators decided that a stepped wedge cluster trial is the best design for their study. They did the trial at 12 hospitals. They ended up with just almost 7,500 surgeries over a 7-month period. Their primary outcome was red blood cell transfusions within 7 days, and they did find a significant reduction in the rates of red blood cell transfusions, which is great. Here is the design of their trial. A design is always very, very helpful. A diagram is always very, very helpful to understand a trial design. So here you can understand exactly how they did it. They had these 6 groups or waves. They had 2 hospitals randomized to each of these waves. They crossed over at monthly intervals, more or less, monthly intervals. So at the beginning, all of the sites were doing the control. That's just usual practice. And then gradually the hospitals started adopting this transfusion algorithm protocol until by the end, they were all doing the intervention. And so these N's are just the patients who were exposed to the intervention and whose outcomes were assessed in each of these cluster period cells. So clearly, these are all different patients, right? So this was a cross-sectional stepped wedge design. All of this is anchored in calendar time. So all of the sites started the trial at the same time. So they had to have the ethics approvals in place and so on at the same time. So note, presumably this intervention could be switched on instantly because they say nothing about kind of allowing a time period or a few days for the intervention to actually be delivered, to train up people to use this algorithm. I don't know exactly how they managed that, but it seems like this was an intervention that could just be switched on instantly. If you don't have an intervention that can be switched on instantly, all is not lost because we often see like there's a small transition period. So a small period where we don't collect any data in that hospital because we're still waiting for the intervention to be delivered. So a transition period is a good idea if your intervention cannot be switched on instantly. So just let me also point out that in the analysis of this type of stepped wedge trial, we're essentially comparing all of the dark shaded cells to the unshaded cells. So in other words, we're pooling all of the data in the shaded in the intervention period, and we compare that to all of the data from the control period. So we estimate a single effect of the intervention. We're looking for a step change, an immediate effect. That's also known as a time averaged difference. Okay, so there is some confusion about what type of intervention effect we are estimating in the standard version of this design. Okay, now what are some of the advantages and disadvantages of a stepped wedge? I want to qualify that a little bit and say a stepped wedge trial has some advantages, but many disadvantages. So you can see I'm leaning towards being a little bit more cautious about the use of this design. Sure, there are some advantages, but there are also many disadvantages. And in fact, when I get a consultation request to help somebody with a stepped wedge trial, I always spend the first half an hour of the consultation to try and talk somebody out of doing a stepped wedge trial, because these trials are really difficult to pull off. Not only are they difficult to pull off, but there are also some serious methodological complications that can cause a lot of problems. We discuss a lot of that in the papers below. I can just give you some highlights here. But let me just first start with what are the main advantages. Why might an investigator consider a stepped wedge cluster randomized trial? So the first consideration, and this is one of 2 of the most popular reasons. There are some other reasons. There are also some misconceptions about the design. Investigators think this is an advantage, but it turns out not to really be a true advantage. But 2 ones that are probably legitimate in most circumstances is, first of all, an investigator might say, look, I don't want to do a parallel arm design because in a parallel arm design, half of my clusters are never going to get the intervention. And it's really difficult to recruit investigators to participate in a cluster trial if they know that they may be allocated to the control arm and never get anything. So they say, it makes it more attractive for me to recruit people to participate, investigators to participate in the trial, if they know at some point during the trial, they're going to get this opportunity to do the intervention. So It's kind of difficult to argue against that. What I often say is, well, have you considered doing a parallel arm design in which you then offer the control arm the intervention at the end of the trial? So that doesn't always go down well. They don't really like that for some reason. They really want to do a stepped wedge. The second reason why investigators like this design is that in many circumstances, it can reduce the required number of clusters for the trial. So recruiting clusters to the trial is really expensive. It's challenging. Sometimes there aren't even that many clusters around. And so we try to minimize the number of clusters that we recruit to keep costs down and to keep the trial feasible. And it is true that with a stepped wedge, our sample size calculation is a little bit more favorable than with a parallel arm design in many circumstances, not always, but in many circumstances. And the reason for that is because with a stepped wedge, unlike a parallel arm design in which we only make between cluster comparisons, in a stepped wedge, we benefit from also making within cluster comparisons. So we compare outcomes within each cluster from before to after the implementation of the intervention. So that's in addition to these usual between cluster comparisons, where we also compare the clusters that are still waiting to cross over to the clusters that have already crossed over. So we've got this combination of between and within cluster treatment effects, and that boosts our power. So we do end up in some situations where the step wedge is beneficial for our power. Okay, but on the other hand, there are some multiple disadvantages. I'm going to just highlight 3. Compared to a parallel arm design, a stepped wedge, number 1, is vulnerable to increased risks of bias. Number 2, it's more complex statistically. Number 3, it's logistically more challenging. I often see this rationale. I did a stepped wedge because of its logistical ease. It made the logistics easier for the trial because I could kind of roll out the intervention gradually. I'm not so sure about that because there are many more logistical challenges raised by the stepped wedge. And so I will explain some of them in detail now. So let's start with the additional risks of bias. What are these? The first risk of bias is confounding by time, also known as period effects. So period effects just refers to the fact that outcomes often change naturally over time, even without the intervention. Things start to improve. Outcomes get better over time. This is also known as a secular trend. And so in our analysis, we have this confounding between our intervention effect and the natural secular trend that happens over time. It doesn't happen in a parallel arm design because in a parallel arm design, everything is balanced on time. There's no period effect in a parallel arm design. But in a step wedge design, because of this gradual rollout, we're mixing up the secular trend with the effect we're trying to estimate, which is the treatment effect. So to analyze a stepped wedge trial properly, we necessarily have to adjust for the period effect. So we have to control or adjust away this secular trend. Unfortunately, there's a temptation, and I see this quite a bit in the literature, that investigators do something like they test whether the period effect is statistically significant, and then they say, oh, it wasn't statistically significant, so I'm going to drop that term from my model, and then I'm going to get a beneficial intervention effect. And often when you drop that period effect, your treatment effect can actually go in the opposite direction. So when you adjust for the period effect, it might be in the wrong direction. When you remove the period effect, it goes in the right direction. And if the period effect isn't statistically significant, it is so tempting to say, okay, I'm not going to adjust for the period effect. But that means your treatment effect estimate is invalid. It's confounded with these secular trends. And so things are a little bit more complicated. And who wants to do a design that's biased by design? The very nature of this design introduces bias. What about the second risk of bias in this design? Second risk of bias is that of time-varying intervention effects. As I mentioned for the transfusion trial, the effect of the intervention that we're estimating is just a time-fixed intervention effect. So we assume essentially the intervention is introduced, it starts to work immediately, and it keeps working. There's only one overall estimate of the intervention across all of those time periods. But that may not be the reality at all. It could be, firstly, that the effect of the intervention varies with calendar time. So maybe this comparison in period 2 between the treatment and control is completely different than the comparison in period 3. Maybe there's a pandemic, or maybe there's some external event influencing the outcomes. Not only calendar time, but the true effect may also vary with duration of exposure. As you can see here, some of the sites do the intervention for up to 3 periods. Some of the sites do the intervention for only up to 2 periods, and some of the sites do the intervention for only 1 period. And it's possible that as you get more experience with an intervention, you get better with it. So the effect of the intervention might actually improve over time. Or the effect of the intervention by nature may lead to like a gradual improvement as opposed to an instantaneous improvement. The opposite is also true, of course. It could weaken over time because people forget the training that they received at the beginning. Now, if those things happen, and we do our standard analysis where we compare all the dark cells to all of the light cells, we have this alarming statistical paper that used simulation to demonstrate how, if we do that, and the true effect of the intervention is in fact gradual, we can get an answer that is in completely the wrong direction. That's crazy. This result is unbelievable. And so it's actually causing quite a stir among people who have already done a stepped wedge trial, statisticians mainly. I don't think investigators paid attention, but we're actually embarking on a project where we are reanalyzing a large number of stepped wedge trials to see whether empirically the results that we've seen in these simulation studies hold out, whereby for those trials where the effect of the intervention is more gradual, do we get the wrong intervention effect estimate from that standard analytical approach? So that'll be really interesting. But at least the simulation studies so far suggest you can get something that is very wrong if you don't pay attention to these time-varying exposure intervention effects. So that's a key consideration for a stepped wedge. It's also more statistically complex. Perhaps I don't have statisticians in the audience, so maybe I don't need to dwell on this, but I mentioned earlier this need for accounting for the intracluster correlation coefficient. Well, in a stepped wedge, things are more complex because we also have these overtime correlations that need to be accounted for. So our hierarchical model is just a lot more complex. If we don't do this more complex correlation structure, we can get, again, p-values that are too small. So that's more complex. I mentioned logistical challenges as well. And I said, well, it is logistically challenging because we have to ensure that all of the REB approvals are in place at the beginning, because these sites have to start the trial at the same time. And you don't know which site is going to have to go first, right? It's all dictated by randomization. Another difficulty is getting sites to just adhere to that planned implementation schedule. So they have to wait to start the intervention until the randomized sequence says they are ready to start the intervention. They can't just decide, okay, I have now fully trained the investigators. We feel ready. Everything is in place. We can now go live with the intervention. No, you have to be ready when the randomization says they need to be ready. And so we often see this problem in stepped wedge, in the stepped wedge literature, where we have implementation challenges with sites being unable to start when they're supposed to start, or being so eager that they start too early. And so all of this leads to deviation from the intention to treat approach, and of course that's associated with bias. So there are many logistical challenges with this design. So because of all of these reasons, The consort extension, I don't know if you're familiar with the consort extension, it's a set of reporting guidelines for clinical trials. We have an extension specifically for cluster trials and another one specifically for stepped wedge cluster trials. So it's very important that we describe why we want to choose this design. So we have to outline our rationale for choosing, number one, cluster over individual randomization. So if you can feasibly do an individually randomized trial, for example, if you're evaluating a drug or a device, individual randomization is certainly feasible. So if you're not going to be using individual randomization for that type of intervention, you should have a clear reason why you want to use cluster randomization. But number two, for a stepped wedge, you also need to explain why you can't do a parallel arm design. Because the parallel arm design is really your most robust choice because it doesn't have all of these risks of bias. So if you are going to choose a stepped wedge, explain your rationale. So that's really important according to the consort extension. So in summary, for a stepped wedge design, my top tips for success would be use a stepped wedge as a last resort. So you have to have a good reason for why you want to do a stepped wedge. And saying something like, I've always wanted to do a stepped wedge, or I think it's going to make my design look better for CIHR to fund this trial, I don't think those are good enough reasons. We always want to choose the most rigorous, the most robust design for our research question, within limits of feasibility, of course. Two, of course, to get an unbiased treatment effect, we have to account for a period effect in our design and statistical analysis and never put pressure on the statistician to omit that term from the analysis because it's going to give us a significant result, although it's very tempting. We have to do this more complex hierarchical model that accounts for these different types of correlation structures. And we should not forget that we have to think carefully about how the intervention works. Is it true that my intervention is going to lead to an immediate effect and it's not going to wane, or it's not going to get gradually stronger with time? Because in those circumstances, I need to do something different with my analysis. I can't just follow the approach that 99.99% of stepped wedge trials do. So I have to consider the potential for time varying effects. Okay, so those are my top tips for a stepped wedge design. So I now want to get back to this transfusion example that I had. Like I mentioned, I have no inside information about this trial. I was not involved in this trial. I just picked it from the literature as a really nice, useful example. I don't know why they chose a stepped wedge design. So they didn't explain their rationale, I'm sure, and this was before the consort extension was published. So I'm sure they had some considerations. They probably considered alternative designs and landed with a stepped wedge being the most attractive for them. So I don't want to go through what could potential reasons have been, but I want to explore one potential reason. So I want to consider if the sample size consideration might have been what drove them. And if so, was that a legitimate reason? So here are the sample size parameters from their manuscript. So they wanted to achieve 90% power, two-sided 5% significance level. They had a stepped wedge with 6 steps. Their control arm proportion was 0.5 for the transfusion rate. And they wanted to detect an 8% absolute difference. So those were their target parameters. They assumed an ICC, maybe they got that from the literature, of 0.095. And they had an average, or they expected an average of about 85 patients per site per month. So each of these intervals, an average of 85 patients across their sites. So those are the sample size parameters. So normally what I do is I first calculate, well, if you could have done an individually randomized trial, you would have required about 1,600 patients. In this trial, they couldn't feasibly have done a patient randomized trial because it was an intervention that was kind of administered to the providers at the hospital level. So clearly, they couldn't do a individually randomized trial. But had it been possible, the sample size would have been 1,600 compared to the 7,000 that they needed for a stepped wedge. So I replicated their sample size calculation, got the same answer for the stepped wedge. They needed 12 hospitals and about 7,500 patients to do this trial. So here's the diagram of their design. So K in my notation here is the total number of hospitals that they needed, and N is the total number of patients or individuals. So this is their exact design. So I wanted to think through what would have been the implications had I told them, no, you have to do an individually, you have to do a parallel arm design as your first choice. So maybe they considered that. Maybe they looked at a parallel arm design, and the sample size calculation was completely infeasible, right? So if you do a standard sample size calculation for a parallel arm design, probably unrealistic to think one would ever want to do a cluster trial design with a 1 month duration. I don't think that's typical, but to keep things comparable, I'm choosing a 1 period parallel arm cluster design. So imagine they had to do this 1 period where they could recruit 85 patients in each of these hospitals. They would have required almost 200 hospitals. So clearly, I'm sure there aren't even that many hospitals available in, say, Ontario. And so this design would have been infeasible. That's clear. But then I normally say, well, we can always do a before and after parallel arm design. With the before and after parallel arm design, all of the hospitals start the trial in the control, and then half of the hospitals cross to the intervention. The other half carry on with the control. So we're adding basically a control before measurement in all of the hospitals. That dramatically reduces the required number of hospitals. So we get a lot of benefit, gain in statistical efficiency and power by just adding that before measurement. But it's still probably infeasible. Maybe it's too much, too expensive, can't recruit that many hospitals. So what I then looked at is, well, this parallel arm before and after design takes place over only 2 months, whereas their stepped wedge takes place over 7 months. So what if they did a longer duration for the before and after in a parallel arm design? And quite interesting, in that case, I get a parallel arm design could have given them about the same power for the same number of hospitals as the stepped wedge. So they could have done a parallel arm design and avoided all of these logistical complexities of a stepped wedge, having to ensure that all of these sites are ready to start the trial at the same time, having to ensure that all of the hospitals cross when they're supposed to cross, making sure or being worried about pandemics or external events influencing things and skewing the results in one direction or the other. They could have done a parallel arm design with the same number of hospitals and, in fact, slightly fewer patients as well, and a slightly shorter duration. So I normally like to go through these exercises with investigators and just present them with what their options are. So here I would have tried to push a little bit for a parallel arm design because it works with the sample size that they had available. So just to note that some people say, well, I don't want to do a parallel arm design because it's infeasible to implement the intervention at the same time in so many hospitals or in so many sites. I like the staggered introduction of the intervention. Well, that's a misconception because we can do a parallel arm design with staggered implementation. There's no reason why a parallel arm design has to have all of the sites in the intervention arm start the intervention at the same time. So we could, for example, do our parallel arm design in batches. So we might have, say, 4 hospitals start the trial in wave 1, whereby 2 switch to the intervention and the other 2 stay in the control. So they remain concurrent controls for the interventions there. And then we have another batch of 4 hospitals with their concurrent control. And then finally, a final batch of hospitals as well with the concurrent control. So there's no reason why the staggering has to have any special benefit in a stepped wedge. Okay. I hope I haven't lost everybody. So in the final few minutes, I just want to make you aware of some resources that you could potentially access to help you think about some of these considerations. The first is sample size calculation. So it actually has become very, very easy to do a sample size calculation for a stepped wedge trial and for a cluster trial, because we have this really nice R-Shiny app, which is basically a menu-driven R application where you can just plug in all of your sample size parameters and it will spit out your required sample size for any type of parallel arm, stepped wedge, cluster crossover, before and after parallel arm type of design. So you need all of your input parameters, put them into the app, and it gives you a sample size. The NIH, Dr. David Murray, also has a very nice sample size calculator, menu-driven sample size calculator for parallel arm cluster trials, individually randomized group treatment trials, and stepped wedge trials. It's very easy to use. There's a website at Queen Mary University of London that has a lot of publications and resources and links to sample size calculators. Here's a very nice blog maintained by Richard Hooper at Queen Mary University of London. Very interesting. He makes use of, it's a really interesting blog style discussion about stepped wedge trials, quite hilarious. I can highly recommend looking at that if you're interested. And then also we have a nice app if you're worried about these complex intracluster correlation coefficients that are required for a stepped wedge trial. If you have routinely collected data and you want to know how can I use these data to estimate these ICC parameters that I need for planning a trial, we have an app that allows you to just upload your numerator and denominator data across multiple periods, across your multiple potential sites, and it will spit out for you your necessary intracluster correlation coefficients that you need for designing your trial. So we just had like 50 minutes to go over some highlights of this design, but there are many more resources. There's a 3-day short course on cluster trials and stepped wedge designs at that link, and various other links. I'm happy to make the slides available should you be interested in following up on those. So just in conclusion, cluster trials can be useful, but I generally recommend patient randomization when it's feasible. Stepped wedge design also have some advantages, but first choice is usually a parallel arm design. And I definitely would recommend working with an experienced statistician if you are interested in conducting a cluster trial or a stepped wedge. I have some references there, and at that point, I'll stop sharing and check if you have any questions. Thanks very much.
Dr. Taljaard, that was excellently delivered. This is not an audience of statisticians as you observed, but I think you pitched that just right for this audience to explain a pretty complicated subject and one that I think we do need to understand. As there's I think you would argue in a sort of a laboratory-based or even a transfusion medicine-based research environment, patient-level randomization is often just really difficult. When especially when you're looking at sort of packages of interventions. If I could just ask, the quick question before I open this up to the floor, I think my understanding, the advantage of patient-level randomization is supposed to be that it eliminates or minimizes the risk of imbalance in your allocation, that you will have the same kind of patients getting the interventions, getting the control. And I always thought that the stepped wedge was, more immune to that kind of risk of having an allocation skewing effect than the parallel cluster randomization, because you're going to, any kind of differences between the clusters will be accommodated by the fact that all your patients are going to be getting both interventions. So is that not the case? Is that not an advantage of the stepped wedge approach, that you'd have less risk of having differences between your control and your intervention arm than you would with a parallel cluster trial?
Well, it's partially true, because remember, in a stepped wedge, our intervention effect is estimated, as I said, both from that before and after comparison, but also between cluster comparison, right? So it's a mixture of both of those. So the before and after comparison is potentially at less risk of imbalances because of characteristics being different, because it is a within hospital comparison. So to the extent that the hospitals are very different and recruit very different patients, you tend to control for that. But you still have the between cluster comparisons, which could be skewed. But a bigger concern is this idea of secular trends, because if you think about, okay, so why are we using randomization in a step wedge at all? If it's true what you're saying, that we can just use the before and after comparison, which controls for bias, we wouldn't need to do the randomization, right?
Mm.
But that could lead to bias across these calendar periods, and that could lead to skewed data as well. And so that confounding with the secular trend is a key consideration. And if something happens at any point during your trial, as your data has been accruing, those data are imbalanced because you've got more patients in the control in the beginning and less patients in the intervention. And towards the end, you've got more patients in the intervention and less in the control, right? So that could lead to a skewness if there's like a shock or some external event influencing all the sites in a particular calendar period, right? So those things could go in the opposite direction. Now you end up with imbalances again. And so those things don't happen with a standard parallel arm design, and they don't tend to happen with patient randomization because we randomize so many thousands of patients, right? And so things just even out over time.
Mm-hmm. Yeah, I guess, we're used to spotting bias in allocation, but we look at our table one, we're like, oh, look, all the intervention arm patients were younger or sicker or what have you. But the type of bias that I guess the step wedge introduces, that temporal bias, is harder to see, I guess. When you're,
Yeah.
a layperson is reading the paper, all you can, you don't, it's hard to kind of like look at a table and see, oh, well, this was skewed by, what happened over the course of a year. So maybe it's taking a bias that we can see and replacing with a bias that maybe we can't see as well.
Yeah, and even just producing that table one is more complex in a stepped wedge. So there are different ways that people approach this. So some people just present their usual table one the way they would for any patient randomized trial. So they take the bottom triangle, the control arm, they summarize all of those patients in, one column, and then the upper triangle, all the intervention patients, they summarize those in another column. So that would just be the usual standard comparison.
Mm-hmm.
But then you kind of hide this, you don't really see if there's an imbalance based on how you've randomized. So normally we like to see if our randomization worked. So sometimes people suggest presenting it also by row, to see if you managed to successfully equalize the characteristics of these sites across the rows, across these calendar periods.
Interesting.
But that could be a nasty looking table if you have a lot of rows.
Okay. If anyone in the audience, if anyone have any questions or comments on this topic, I think it was a great choice of paper to review because we're all very familiar with that paper. It definitely changed practice at many of our hospitals.
Oh, great.
Hi, my name is Yev. I'm a transfusion fellow over at Beth Israel Deaconess in Boston. I'm interested in clinical trials, but as they relate to like patient education. And I was wondering if you can comment on like I'm looking at ways how to get involved into that space, and also if you can comment on maybe like the step wedge versus the traditional approach to like patient education and outreach, and like maybe pros and cons of both, because I haven't seen too much step wedge kind of work in the patient education field, but I was wondering if it's applicable in that sense as well. Thank you.
Yeah, can you explain what you mean by patient education? You're not talking about patient engagement, right? You're talking about interventions that aim to educate patients about some aspect of their care, or?
Right. Like, so say like if it would be like a patient education program, either in like pathology and surgical pathology or in clinical pathology, where patients could come into like a clinic and maybe review some of the results and kind of integrate that as part of their clinical care with their hematologist, oncologist, or surgeon if they need to, if they want to review some of their kind of lab results, and pathology being better to provide that service. So it's more like if there's like an arm where it's kind of standard of care versus an arm with like a patient education care, and kind of going like that, if that makes sense.
Yeah, I would wonder in that situation, it seems as if the intervention is something that's done one by one to each individual patient. So I would ask you if that intervention is divisible at the individual patient level. So could you feasibly randomize patients? Or is it something where you think you do need to randomize providers and have all of the providers treating the same patient either do the education or not? So I'd like to understand your rationale for why you think, potentially a cluster randomized trial is necessary in that case. It sounds to me as if a patient randomized trial might work, but if it is something that needs to be done en masse, whereby the education is delivered to all the patients at a particular site, then I think, a parallel arm design is probably the first choice. I must admit, I don't see a lot of step wedge trials that have patient-directed interventions. For step wedge trials, the types of interventions that we see most often are like health services delivery type interventions that are more targeted at the environment, at the providers.
Thank you. And is it okay if I reach out after via email just for some other questions too?
Yeah, absolutely. Yeah.
Okay. Thank you.
I think we've got time for maybe one more quick question. Okay, so maybe we'll let people sit and digest this. I think that was very, very helpful. And I'm so happy you provided all those additional resources for people who want to dig a little bit deeper into this area. That's very helpful. So I guess with that, we'll adjourn for the day. Dr. Taljaard, thank you again very much for putting that talk together and presenting to us. It was really appreciated.
Okay, you're very welcome. Thank you. Bye-bye.